Okay, so talking about or referring back to a form of surgery I mentioned earlier in the lecture, we're using the combining form laparo to describe abdominal wall. Just at the end of the last segment, we were talking about appendicitis and appendectomy, and those are usually performed in a laparoscopic setting. And so they're performing the act of laparoscopy, the visual examination of the abdominal cavity, using a laparoscope, which is an instrument used to visualize the abdominal cavity. So as you can see here, this is the classic 3 incision points. Looks like this is an appendectomy. There's the laparoscope itself is going in through the umbilicus. You can see that to the upper right as it descends down into the frame and then goes in through the umbilicus. So that's what they're looking at. And then they have surgical tools in these other 2 incisions that are going in and doing the actual work, doing the actual appendectomy. So viewing through the laparoscope, performing the procedure with the other two instruments you see here. There are mechanized ways of doing this too. They have a robot. In fact, they have one down at Dominican that can do surgery remotely while the surgeon stands outside of the room and controls the devices. And it's kind of cool to see. So anyway, laparoscopy is dealing with lapro, the combining form for abdominal wall. And towards the end of the digestive tract, no pun intended, we have the rectum. Recto is the combining form. Rectal means pertaining to the rectum. So following the descending colon down, it turns into the sigmoid colon, which then turns into the rectum. And that's what you're seeing here in this illustration. Barium enema. This is a form of X-ray we can perform on a colon. It's usually done with fluoroscopy, but and as I mentioned earlier with the barium swallow, this is the same sort of procedure, except it's going the other direction. So in a barium enema, they're doing an X-ray of the rectum and colon after administration of barium sulfate. That's partially true. It's not just an X-ray, though. It's actually a fluoroscopy, much like I described earlier, so they can watch the actual function of the barium as it's moving through the colon. So it's inserted through an enema, and then it's observed via fluoroscopic examination. And when all that's over, we take a series of X-rays, usually 6 or 7 X-rays of different parts of the colon to finish the complete exam. And that's a barium enema complete. And at the very end of the digestive tract, the very opposite end from the oral cavity is the anus, combining form ano. Anal means pertaining to the anus. You can see in the diagram here, the rectum is just superior to that. Anus is the actual portal to the outside environment through which defecation occurs. If there's a reason to talk about pathology that involves the anus and the rectum, instead of saying anus and rectum repeatedly, we would use the combining form procto to refer to the anus and rectum as a combo. As in proctology, the study of the anus and the rectum, and that's of course performed by a proctologist, a specialist in the study of the anus and the rectum, and proctitis, inflammation of the anus and rectum. Once again, inflammation can happen anywhere, and this is one of those places. And if so, we call it proctitis. You would see a proctologist, and they would perform an active proctology upon you to try to resolve that inflammation. And another pathology that a proctologist might be interested in would be a hemorrhoid. So this is a mass of enlarged, twisted varicose veins. It happens in mucous membranes, and there are 2 types. There's an inside, which can happen inside the rectum itself, or outside, external, which would be the anus. And so you see depictions of them here, usually bearing down hard during bowel movements repeatedly will cause hemorrhoids. Hemorrhoids are common through natural childbirth because of the amount of pressure that the mother has to exert in bearing down to force the baby out. So those are common and they're associated with childbirth. And if they're troublesome or cause any problems, they can be treated by a proctologist. In many cases, a standard general physician can also handle hemorrhoids. And bowel movement, I just mentioned a moment ago. So this is discharge of waste matter in the form of feces from the large intestine, otherwise known as defecation. It's abbreviated BM. The Bristol stool chart for you nurses will be something important. And this gives us information about hydration and about how the digestive tract is performing. So dehydration is going to look like type 1. And as things get more hydrated, type 2, type 3. Type 4 is exactly what we want a bowel movement to be. Type 5 is now leaning more towards diarrhea. Type 6 is going directly to diarrhea. And type 7 is watery with no solid pieces. That's entirely liquid. I'm going to apologize for the next slide, but it's still in my slide presentation, although I swear every semester I'm going to remove it. the word diarrhea, which means through. Of course, the prefix means through, and rrhea is discharge or flow. Putting together, diarrhea, passage of frequent watery stools. Once again, apologies for the picture. One of these days, I will remember to remove it from these slides. Hematochezia versus melena. So hematochezia are red, bloody stools, and that's a lower GI bleed. And if you remember, we talked about melano, meaning black, and melanin as being the component that gives color to your hair and to your skin. Melena also is using the term black to describe black, tarry stools. That's an upper GI bleed. Hematochezia, this red one that you see on this 4x4 here, that's less concerning. That could be a hemorrhoid or something in the lower or very low GI tract that might be actually something that could be resolved within a physician's office. Melena, however, that's blood that's been gone through the digestive tract. Your body has partially digested it, and it comes out looking, as you can see on this example here, as a black tarry stool, and that is something that's definitely more concerning. Melena is often associated with esophageal varices, which are blood vessels that enlarge in the esophagus, usually secondary to alcoholism. And of course, it bleeds into the stomach, which then the stomach digests it, and it comes out looking like this. It can also be an indication of colon cancer. There is some association with melena and colon cancer. Either way, if you're seeing red bloody stools or black tarry stools and you're concerned, especially if the black tarry type, you definitely should seek the help of a physician. You're going to need a diagnosis and probably a colonoscopy and maybe some other studies to find out why. A hernia. This is a projection of an organ or part of an organ through the wall of a cavity that normally contains it. I think I've mentioned this before when we talked about hernias in the inguinal area, which is the kind of the groin area. And these are the different types of hernias. So you have epigastric is above the abdomen at the midline, incisional at the site of a previous surgical incision. One of the things that were resolved through the use of laparoscopy were surgical hernias because they no longer had to cut the abdominal wall open. Therefore, an incisional hernia risk was substantially less. So this is, an organ poking through a muscle wall, and it shouldn't. We have an umbilical hernia. You see there in the center, that's the umbilicus herniation. A direct inguinal is near the opening of the inguinal canal. The indirect inguinal is at the opening of the inguinal canal. So either one of those can be associated with the inguinal canal. And when we get to the reproductive chapters next week, we'll talk a little bit more about what that inguinal canal was all about. And then we also have the femoral herniation here. This occurs in the femoral canal. So any one of these places can be a weak spot where an organ may push through a muscle wall, protrudes into the outer skin surface, and then you can see it as you can in this picture, and would require a doctor's attention, although it may not require repair. It might very well be that it's a herniation that can be managed differently. I talked about colonoscopies earlier, and I mentioned that I had polyps when I had my colonoscopy, my initial one, that were cancerous. To clarify, a polyp is a small tumor-like growth that projects outward from a mucous membrane surface. In this case, you are looking at a polyp in the colon. There's no way of knowing if this is cancerous or non-cancerous by looking at it. You have to biopsy it. So the snare that you see on there is connected to a wire, and that's actually a mechanical mechanism. Well, it's a mechanism, not mechanical mechanism. It's a mechanism in and of itself. The snare gets pulled, the wire grows taut around the polyp, and it removes the polyp. Another tool will then take it, extract it from the rectum or the colon, wherever it's found. It will then be put into a formaldehyde, sent off to pathology, and they'll determine whether it's benign or malignant. This is what they look like. You see also, so the picture I'm referring to has been over here on the far right. If you look over on the left, you see another photograph of a different type of polyp. It sort of looks like a mushroom growing, and that's the variation there. I've looked at lots of colonoscopy reports as a medical assistant, and I've seen lots of pictures of polyps, and there's a huge range of what they look like. They do not mean cancer, because there are plenty of benign polyps as well. They may be a good reason, however, to biopsy to make sure it's not cancer. Diverticulum. These are small pouches in the lining of the colon or the large intestine that bulge outward through weak spots. So, as I've talked about before, collagen breaks down in their bodies as we age, and of course, the colon is constantly being flexed and contracted due to the movement of feces through it. After a certain amount of time, that tissue starts to wear out from that constant stress of being stretched out, and then, of course, collapsing again. So, these little small pockets can develop as a result of the collagen breakdown. The skin doesn't have the tone it once did, or the tissue rather, doesn't have the tone it once did. And so, as a polyp would stick into the lumen of the colon, it would be inserted in. A diverticulum is a pouch pushing outward, which means it can trap things, right? And if it does, you could end up with diverticulitis, or your patient could end up with diverticulitis. This is inflammation of the diverticula. So, diverticula is kind of like plaque in your arteries. You're going to have them if you live long enough. For most people, they're never going to be a problem. For others, they're going to be a problem constantly, and they may show up younger in life than we would expect. And when they flare, it's called diverticulitis. What happens in this condition is that stool becomes trapped inside a diverticular sac. This causes inflammation, infection, fever, and severe abdominal pain. It's usually cured by treatment with antibiotics. And if it becomes too problematic, it could result in surgery. And surgery, of course, it could end up in a colostomy, potentially. Most diverticulitis cases do not end that way, but I have seen some that do. So it's just a reason to pay attention to that part of the colon, to treat it. And the antibiotics, of course, are going to be helpful in keeping inflammation and infection low. And that's, of course, what we want to do is prevent infection. Excuse me, our last word is based on a suffix with a very short prefix put on the front of it. Orexia means appetite. Anorexia means without appetite. So we take the prefix "an", put it on the suffix orexia, and we're describing actually a state of hunger. So if you'll see in patients' charts, if you work in a hospital or even in a clinic, the patient may report being anorexic at mealtime, which just means they don't have an appetite. So in a hospital setting, food service shows up, they deliver the tray to the patient, they're like, "I'm not hungry, please take it away, I don't want it." The nurse will chart that as the patient reporting anorexia. It is not the same as what we see in the photograph on the left, which is the disease state of anorexia, which is a psychological conundrum where the person may look like the person you see in this picture, but when they look in the mirror, they see someone who's fat and overweight, and it becomes a tricky balance. And it's a psychological disorder, as well as an eating disorder that needs to be addressed. Only reason I point this out is I want you to understand that there are two ways we use this word. We do use it to describe the disease state that's illustrated by the photograph of the young lady here, but technically it means without appetite. So if you see it in a patient's chart, do not become alarmed. If someone reports you as being anorexic, it's probably because you declined a meal when you should have, not that you have a disease state. So just want to be clear on that one. Here are your abbreviations that you'll need to know for the exam this week. We covered them as we went through the exam, or as we went through the PowerPoint, so I'm not going to go over them again. Do have a look over because some of them will appear on your exam, so it's good to know them. That's everything you need to know about Chapter 6, the digestive system. Just enough medicine to be dangerous. So go forth, study, learn those words, and be ready for this week's exam. And we're going to start Chapter 7 here in just a moment. Thank you.